Welcome to Bone Break, the 10-minute podcast that covers basic orthopedic content for the aspiring orthopod. Get a coffee, go for a walk, or just sit back and relax. It's just bones for 10 minutes. Today's topic is clavicle fractures. A 23-year-old non-binary person presents to the emergency room after colliding with another player in the shoulder during a game of football this evening. They have pain in their shoulder and over their collarbone. They are otherwise healthy. They do not have any allergies. They had their tonsils removed when they were 16 and top surgery a year ago. They work as an apprentice carpenter. They don't drink but smoke cannabis on the weekends with their friends. They are right-handed. On physical exam, the patient is unable to raise their shoulder above their head, and they are in a makeshift sling their coach gave them. They are tender over the mid-shaft of the clavicle. There is a slight abrasion over the clavicle, but it is not bleeding and looks superficial. There is no tenting. They are neurovascularly intact. AP and cephalic x-rays of the clavicle are ordered. Radiographs show a right mid-shaft clavicle fracture that is minimally comminuted but displaced. The patient is given a proper sling and told to follow up in the clinic in a week. They are instructed to be non-weight-bearing until then. At the clinic, the attending orthopedic surgeon discusses the benefits and risks of surgery. The patient opts to undergo surgery after a thorough discussion about the evidence around clavicle fixation. They undergo an open reduction and internal fixation of the right clavicle without complications. They return to the clinic 2 weeks later for suture removal and begin to rehabilitate their shoulder. We hope after this podcast, you can describe the important findings you should look for on physical exam of a clavicle fracture, outline the diagnosis and management of clavicle fractures, have an early understanding of the operative approach to fixing clavicle fractures, and understand the importance of shared decision-making and evidence-based medicine in orthopedic management. Clavicle fractures are a common orthopedic injury and are often seen in young, active individuals, most commonly males under the age of 30. They are often a result of a direct blow to the clavicle or a fall onto the lateral shoulder, though this mechanism of the injury is more common in older adults. In this episode, we have highlighted a case of an operative clavicle fracture. A 23-year-old non-binary person presents to the emergency room with a right mid-shaft clavicle fracture. Most clavicle fractures occur in the middle third segment, or the mid-shaft of the clavicle. This is because the bone in this area is thinner and lacks any muscular or ligamentous attachments. The clavicle is shaped like an S and is flat laterally, tubular centrally, and prismatic medially. Fractures can be described as proximal third, mid-shaft, or distal third. This case addresses mid-shaft clavicle fractures. There is an envelope of muscle attached to the clavicle. Medial structures include the sternocleidomastoid, the pectoralis major, and the subclavius. The lateral structures are the trapezius and deltoid. The platysmus drapes over the anterior-superior aspect of the clavicle. All the ligaments that end in clavicular are named for their connection to the clavicle, such as the acromioclavicular, which connects the acromion of the scapula to the clavicle, as well as the coracoclavicular ligament, which connects the coracoid to the clavicle. What further information would you want to know about this patient? What physical exam findings are important? As always, do a thorough ample history as we demonstrated in episode 1. As an orthopedic surgeon, you are likely to work with a diverse range of patients, including those part of the LGBTQ+ community. In this case, the patient identifies as non-binary, meaning they don't feel that their gender falls into the traditional binary between woman and man. Non-binary people may or may not undertake gender-affirming medical care from surgery to hormones. Unfortunately, this population's fracture risk has not been widely characterized in the literature, but one review by Ramsey et al. Found minimal differences in fracture rate between transgender populations and their cisgender counterparts, although there is a known risk of venous thrombotic events associated with the use of estrogen, similar to those who take birth control. When talking to individuals from this community, it's important to respect their pronouns, avoid assumptions, and remain non-judgmental as you would with any patient. Now back to the physical exam. It is important to ensure the fracture is not open, as that is an absolute indication for operative management. Whether a fracture is open or closed is imperative to the clinical workup. It is further important to look for skin tenting, indicating a potentially impending open fracture. As always, you must do a neurovascular exam of the affected upper limb. Revisit episode 1 to review the upper extremity neurovascular exam, as this was reviewed in the context of distal radius fractures. A proper neurovascular exam is especially important for suspected clavicle fractures, as there is a risk of brachial plexus injury. Following history and physical exam, imaging is ordered. What imaging would you like to get? Standard imaging of the clavicle includes an upright AP. This is important as it eliminates gravity, allowing you to see if there's any displacement. The other view that can be used is the Zanca view, which is an AP view with 15 degrees of cephalic tilt to eliminate the overlapping scapula and allow for better visualization. Oftentimes, a complete shoulder series may also be ordered to evaluate for other associated injuries, such as fractures of the proximal humerus or scapula. Radiographs show a right mid-shaft clavicle fracture that is minimally comminuted but displaced. What structures are responsible for the displacement of the clavicle? In terms of deforming forces for clavicle fractures, the medial fragment can be pulled posterior-superior by the sternocleidomastoid muscle, while the lateral fragment can be pulled inferior-medial by the pectoris major muscle, in addition to the weight of the arm. The patient is put in a sling and told to follow up in clinic in a week. At clinic, the attending orthopedic surgeon discusses the risks and benefits of the surgery. The patient opts to undergo surgery after a thorough discussion. What are the risks and benefits of surgery for clavicle fractures? Surgery is relatively indicated in this situation, but can be absolutely indicated in the following: open fractures, displaced fractures with skin tenting, or fractures that have an associated subclavian artery or vein injury. As with any operation, the risks include bleeding, infection, and nerve damage. Again, these fractures are in the neighborhood of important structures, like the subclavian vessels and the brachial plexus, which puts them at risk for injury during an operation. Prior to publication of a randomized prospective trial performed in Canada 15 years ago, clavicle fractures were most often managed without surgery. However, it was found that non-union was a significant risk, especially for highly displaced and comminuted fractures. Hence, there have been multiple studies looking at who and when we should operate on these fractures. For those who are non-operative, there's about a 25% chance of non-union, of which 50% of those patients will be symptomatic, leading to them having a surgery anyways. For operative patients, there are predictable outcomes, but with a rate of 8 to 30% needing hardware removal, hence having a second surgery. In general, healthy active patients should be offered an operation for displaced fractures. However, the decision to operate on clavicles is often made with the patient depending on their daily activities. An orthopedic surgeon should be skilled at discussing the evidence with the patient and be able to engage in shared decision-making about the patient's health. In this case, the patient is a manual laborer and needs their arm for work. Operating on this fracture will allow them to return to work sooner, which may be important for some patients. The patient undergoes an open reduction and internal fixation of the right clavicle without complications. What nerves would be at risk during this operation? There are superficial nerves that are branches of the supraclavicular nerve that often run transverse across the fracture site within the substance of the platysmus muscle. If these nerves are transected, the patient may have post-operative numbness over the proximal chest wall. What approach is used to approach the clavicle? For open reduction and internal fixation of clavicle fractures, an anterior approach is used. Dissection over the clavicle goes through the muscle fibers of the platysmus, and ideally the pec major is left intact. There are no major nerves at risk. However, it's important to remember that the brachial plexus and subclavian artery have a variable relationship with the clavicle, so careful dissection is required. When placing hardware onto the anterior surface of the clavicle, one should be careful as the lungs are just below, along with the subclavian vessels. They undergo an open reduction and internal fixation of the right clavicle without complications. They return to the clinic 2 weeks later for suture removal and begin to range their shoulder. Core questions. The following questions are key concepts about this topic you should review prior to your rotation. What is the common mechanism of injury that causes fractures in the clavicle? What muscles and ligaments attach to the clavicle? The attending questions. The following questions are more advanced, and for those who are looking to impress on their rotations. These topics should be further studied and read about. What structures are at risk during a clavicle ORIF? What are the absolute indications for a clavicle ORIF? We hope after this podcast you can describe the important findings you should look for on physical exam for a clavicle fracture, outline the diagnosis and management of clavicle fractures, have an early understanding of the operative approach to fixing clavicle fractures, understand the importance of shared decision-making and evidence-based medicine in orthopedic management. This podcast is designed for you to re-listen and test yourself at each core question, as indicated by the bell. Thank you for listening to Bone Break. I'm your host, Dr. Kate Van Kampen, an orthopedic resident at the University of British Columbia. We will see you next time to learn about the most common geriatric injury, hip fractures.